Good evening, Arun sir. Ani ma'am, shall we start 7 exact 7?
Meaning 6:30, right?
Sorry, 6:30. Sorry.
Yeah, sure.
Okay, okay.
Hi, Santosh sir.
Hi, Dr. Annie. Good evening.
Hi, Dr. Arun. Good evening.
How are you, ma'am? It's been a while.
Yeah, been a while. Going on, just recovering from LRTI.
So, so my video has this background on its own. This is nice.
I think they did that. I don't know why mine went off.
Okay.
They
No,
have
I did
made the
that,
background.
but for me, it is already happening. I'm seeing my face with the background. That's good.
Yes.
Good evening, Sanal sir, Sindhura ma'am.
Hi,
Hi.
good evening. Good evening. Good evening.
Ma'am, shall we start?
Yes, sure.
Okay. So, good evening, everyone. On behalf of the International Association for Integrated Oncology, it's my great pleasure to welcome all our esteemed faculty members and participants to today's Expert Insight webinar on optimizing treatment sequencing in the era of precision oncology in HER-positive breast cancer. Today's discussion will help us better understand how to optimize treatment sequencing and personalized therapy of our patient with HER2-positive breast cancer. Thank you all for taking time out of your busy schedule to be with us. Before we begin, it's my honor to introduce our program director, Dr. Ani Kanchanba, Associate Professor, Department of Medical Oncology, St. John's Medical College and Hospital, Bangalore. Dr. Ani Kanchanba is a highly respected medical oncologist. Ma'am, thank you for leading today's academic initiative. I would now request you to kindly deliver the opening remarks and formally introduce the theme of today's meeting. Over to you.
Thank you so much. Thank you, Shubhashri, for that humble introduction. Good evening, everyone, and welcome to this scientific webinar on hormone receptor positive metastatic breast cancer. Thank you, International Association of Integrated Oncology, for having these academic webinars at regular intervals, which help us brush up our knowledge about the existing data as well as the upcoming data, so that we are up to date with the recent advances that are happening. And today we chose the topic that is metastatic breast cancer, which is hormone positive, HER2 negative. And it's my honor and privilege to welcome all the dignitaries who have taken the time out and be a part of this scientific discussion. Thank you all. Thank you for sparing time and to be giving the lectures and also being a part of the panel discussion. Dr. Arun, Dr. Meena, Dr. Santosh for accepting the last minute invitation, all the panelists, Dr. Sanal, Dr. Sindhura, Dr. Nivedita, and Dr. Arun giving us the insight about the landscape. So without further ado, let's dive into the first session of today. And I invite Dr. Arun to take the first session.
Thank you, Dr. Annie. Organizers, can you help? Shall I share my screen?
Yes, sir, sure.
Okay, just a second. Just let me know if my screen is visible.
Yes,
And
sir,
I'm not-
visible. Visible, sir.
Okay, awesome. So at the outset, first, I would like to thank Dr. Annie for the kind invitation. So I'm Arun Kumar. I'm a molecular geneticist by training. And so I've been into this domain of precision oncology for a while now. So here I'd been tasked to give some insights on endocrine resistance, particularly sensitivity and resistance to endocrine therapy in breast cancer. So basic disclaimers. Sorry, one second. The slide is not moving. So the disclaimers, this is for healthcare professionals, and the views, opinions, and data presented in this presentation are solely by myself, and my organization does not have any role into any of these that I'm presenting. So I'm participating in this on my individual basis. So this is the agenda for today. Let me quickly jump into the topic. So first, I wanted to showcase this one of my favorite slides, and I think this is the most recent last month published ESMO guidelines on her hormone positive or ER positive and HER2 negative metastatic breast cancer. And what is quite interesting to see is that from the first line, you have genomic mediated therapeutic options available, be it the PIK3 wild type being one of the important factors for choosing the first line, or PIK3 mutated, AKT mutated, ESR1 mutated, BRCA mutated. So the biology of hormone positive breast cancer is being understood more and more, and so is the therapeutic landscape of this subset of breast cancer is widening. So what exactly goes behind this is what I'm going to try to cover over the next 10 to 15 minutes. So let us get into the basics. I know this may be a bit classroom kind of a picture, but I think this is going to be understanding the pathway of estrogen receptor is very critical for us to understand and appreciate what are the other pathways that lead to resistance to it. So basically, when you have a estrogen receptor being activated, it not only activates the regular estrogen receptor pathway, it also on the side activates a PIK3 pathway. It can also have an impact on the MAP kinase pathway, so on and so forth. But in a healthy cell, what happens is, so this is the mechanism of action of endocrine therapies, but let me just focus on the panel A here. Basically, estrogen is produced from androgens using the enzyme aromatase. And this estrogen binds to the estrogen receptor alpha, which dimerizes, and that dimer goes to the nucleus to have further downstream gene activations that are involved in cellular transcription, that are involved in cell mitotic index increase, that are involved in further other aspects or other characteristics of a tumor cell. Now, this is what happens in a general endocrine mechanism, which is tightly controlled. how we are understanding of this, how we are going to have therapeutic strategies is one of the most commonly used is the aromatase inhibitors, where you inhibit the aromatase enzyme, anastrozole, letrozole, or irreversible aromatase inhibitors include your exemestane, etc. You also have some selective estrogen receptor modulator, where these molecules competitively bind to the estrogen receptor. And if they bind to the estrogen receptor instead of the actual estrogen, then the downstream gene transcription is prevented. So this is what is the activity of SERMs, as we would say. Example is a tamoxifen. Then you have SERDs, which are selective estrogen receptor downregulators. So here, if these SERDs, which compete with the actual estrogen to bind to the receptor, then the whole ability of this complex, estrogen receptor dimer complex, to bind to the regulatory element in the nucleus is lost. So they completely disrupt even the binding of this estrogen receptor into the transcriptional initiation site. So this is the next class of molecules called SERDs. And lastly, we have PROTACs, which is quite an interesting one, where you have a estrogen receptor ligand, and you have the linker, and you have a E3 ligase ligand. So what happens is every protein in the cell undergoes natural degradation using E3 ligase, and you create a protein chain which binds to the estrogen receptor. And when this protein chain, synthetic protein, binds to the estrogen receptor, that leads to the degradation of the entire protein. That includes your estrogen receptor also. So they are this whole group of therapeutic molecules called PROTACs, proteolysis targeting chimers. We have seen what the pathway is. We have seen how this pathway is also used in therapeutic strategies. Now let us come to understand how different genes are involved in the resistance to this pathway. Now, activation or sensitivity to this pathway is simple. They produce excessive estrogen, or there is a excessive estrogen receptor expression in the cell. But when we start treating the patient with the particular, be it the SERD or the SERM or letrozole or anastrozole, how do they develop resistance? So to deal with, I'm showing one of the very seminal studies that happened in 2018, where genomic landscape of a large set of endocrine resistant advanced breast cancers were found, and these were the list of genes that were mutated. Now, most common one was the ESR1 and the TP53, but apart from that, you also had ATR, HER2, APC, so on and so forth. Now, how do we make better sense out of it? So when we try to understand the pathways behind each of these genes that are mutated here, you could broadly classify them into MAP kinase signaling pathway and the transcriptional regulation pathway. Now, remember, this is a 2018 study. After this, I will come to a more recent study, which will also help you understand how science has evolved. So those with mutation in the MAP kinase signaling pathway, genes include your HER2, NF1, EGFR, HER3, KRAS, BRAF. All these can cause resistance to hormonal therapy, or in what we call as endocrine resistance. Now, what is the significance of it? The duration of aromatase inhibitor therapy is given on months here, and the same for SERD therapy. All of them have a very poor outcome, right? The green one being the ESR1 mutant cases. The red one is the MYC, which is your transcriptional regulation group of genes. And for the red one is your, I'm sorry, the blue one is your MAP kinase altered gene set of cases. So all of them seems to have a very poor progression-free survival, and the duration of therapy is much limited. And interestingly, this study was also one of the first to identify there is a good chunk of patients who are showing primary resistance. That is, when the tumor initiated itself, they seem to have mutations that impact the MAP kinase pathway, or the SWI/SNF is basically your transcriptional or chromosome modifying pathway. So this was a very interesting identification where almost 40% of the cases which had a MAP kinase pathway alteration had it upfront, and majority of them had HER2 mutations. So this is again quite important for us to know. Not just HER2, it also had RAS, RAF, MEK, and other mutations. So what you see in green is acquired mutation. What you see in blue is your pre-existing mutation. So it is imperative for us to identify what is the mutations that is there upfront so that you can be prepared to look out for early signals of primary resistance in the patient to endocrine therapy. Now, many of these mutations are targetable with various targeted therapies. I'm not going into the details of it, and their particular frequencies are also given. And of course, the PIK3 mutation is the most common. 43% of the patients seems to have PIK3 mutation, and now we have PIK3 inhibitors, AKT inhibitors, or those that target the mTOR pathway as a important line of therapy in these patients. Now, I'll switch gears from a targeted understanding of early study, which was a very seminal study where we understood MAP kinase pathway, which also included the PIK3 pathway in it, or the chromosome transcription, chromosome epigenetic modification genes are also quite important or correlated with endocrine resistance. I shift towards a more recent study, which was published in 2025, where genomic landscape of endocrine resistance in Indian patients was studied from the Tata group, Dr. Sudeep Gupta's group. They had 40 prospectively sampled patients where paired tumor tissue was there along with the normal tissue of the patient, and 20 of them were treatment resistant and 20 of them were treatment sensitive. And as per this study, sensitivity was defined as disease-free at 5 years. Resistance was defined as relapse within 2 years of initiation of adjuvant therapy. Now, they did a whole genome sequencing for all of these 40 patients. And here is what they found. Mutation rate, this is where I just pay a bit of attention, quite interesting to see. So on the green, you have treatment sensitive. That is for 5 years, they did not progress. And this is those who were treatment resistant. Each line that you see here, each block is one individual patient. The blocks are overlapping, but you can see that each rectangle vertical bar is one patient. And on the y-axis, you have the mutation rate in the first graph. Mutation rate was much higher in the treatment sensitive. 4.7 mutations were the median number of mutations compared to 3.1 mutations per megabase of the genome. So these are somatic mutations alone and not the germline mutations. But even though these 3.1 mutation per MB was seen, but they were the treatment resistant patient. Why is that? That is where the type of mutation plays a very, very important role. Now, of these mutations, although both of them are somatic mutations, number of non-silent somatic mutations you see is much higher in the resistant group compared to the non-resistant or the sensitive group. So what do you mean by non-silent? It means that most of these mutations that you saw in this somatic mutations, although it happened in the DNA, did not actually cause a protein change or a considerable change in the function of the protein. Whereas those, even though the number of mutations were less here, the impact on the protein was very high here. Similarly, structural variants, that is, you have deletions, duplications, insertions, inversions, and translocations were much higher in the resistant group compared to the treatment sensitive group. Now, this is more like looking into the broader picture. But when it comes to actual, okay, I'll also complete this. Those who had this telomeric length was much shortened in the treatment resistant group. So not only the number of somatic mutations or the structural variants, the telomeric telomeric length ratio was also significantly lower. So if it is 0, that means it is correct. If it is more than 0, it means it is more, telomeric length is higher. But most of these cases had a much lower telomeric length. And so is the case with the number of copy number variants. So pink means it's amplified and blue means it's deleted. So the copy number variants were also much higher in terms of treatment resistant. Now, we saw at a genomic level in these two slides what it is. But let us look at it at a particular gene level, what it is. Now, the most common type of mutation seen in the resistant is in the PIK3CA pathway. It's in the TP53 mutation and in the MAP kinase pathway mutation, be it your ESR1, MAP3K1, CDH, NF1, all these are MAP kinase pathway mutations, and you don't see these mutations in the sensitive population at all. So again, there is a significant difference. And among the PIK3, TP53, ESR1, and the AKT1 mutations, the frequency of those having the hotspot mutations, which are particularly your mutations in the PIK3CA that cause overly activation of the PIK3CA, is seen more in the resistant and not in the sensitive group. And interestingly, the MDM2 amplification or PIK3 deletion is again very common here. And double-strand break repair failure is again much higher in this resistant group, and you don't see these blocks many in the sensitive group. And deletions in the pol D1, RAD54L are all seen much higher here. Now, what do we synthesize out of this? So, one point here is, in addition to this, there is something called as AID activity. Now, when you do whole genome sequencing,
Sorry to interrupt, sir. Sir,
Yeah.
2 minute left
Sure.
for
I'm just summarizing it. I'm just closing it up. So apart from this, you also have certain genomic signatures like double-strand break repair, AID activity, which are seen more in the resistant group and not in the sensitive group. Now, one another thing which is commonly missed, but very easy, is early on, 7,270 patient samples of breast cancers non-metastatic, which were hormone positive, gene expression analysis was found. Interestingly, in this ER positive group, just pay attention to this second line. You see for pathological complete response, you see the macrophage infiltration was highly correlating. So the size of the bubble correlates to the hazard ratio and the significance of being present or absent. So in ER positive, the pathological complete response was correlated with the presence of macrophage M1. And disease-free survival, again, you're able to see presence of macrophage in the tumor tissue seem to be correlating with the response. And you can see the hazard ratio is 3.32. Above 1 means it's positively correlating. And so was the case with the overall survival. You see the overall survival is here. So it was still correlating. The others are HER2 positive and other subgroups of breast cancer, but I'm not taking it. So the reason I showed you here is, first we saw pathways being activated. We also saw specific chromosomal level aberrations being correlating. And now we also see there is an immune angle to it, where immune cell infiltration or the type of immune cell infiltration also has an impact on the disease-free survival, which means that absence of these specific cell types could possibly cause resistance to the endocrine therapy. But unfortunately, nobody has taken this particular signal further into research unless we understand how the presence of immune cell and the its correlation with the hormone pathway and the therapy that is being given is done. We won't be able to find a cause to effect analysis. So this is my summary.
Sorry to interrupt. So your slide is not visible.
It's not visible.
Yes, sir. Not
Um,
visible. Or not
should
moving.
I
Yeah,
stop
visible,
chat?
visible. Visible, sir.
Okay.
Visible, but I think it's not moving. Yeah. Yes. Now the slides moved. Yes, because it
Yeah.
was stuck at the previous slide.
Okay. I'm now in the summary slide. You're able to see the summary slide?
No, that's again not there.
Are you able to see now? Summary slide. Okay, I'll quickly stop sharing and reshare again. It's the last slide. Are you able to see this?
Yes, yes, yes.
Yes, sir.
Okay. So we saw, I took you through three major studies, which was one of the largest studies having done in hormone-positive breast cancers. The synthesis of it, which I have summarized, is given here. Endocrine resistance is not a single factor. It could be caused by multiple factors. One of the most well-known factors, which we all know, is activation of pathways, such as your PI3 pathway, MAP kinase pathway. MAP kinase includes your HER2, EGFR, and other pathways. So we already have drugs targeting these. And you also have inefficient DNA repair or the HR gene mutations, which you commonly see. HDAC1C1 deletion, TP53 loss. All of these can cause, HR is homologous recombination and not hormone receptor in this particular case. So DNA repair gene mutation or HDAC1C1 deletion, TP53 loss, all of these can cause inefficient DNA repair. And again, that can cause to lead to endocrine resistance. And you also have genomic instability being correlated with endocrine resistance, where we clearly saw high copy number variation or structural variation burden, telomere shortening, chromothripsis. So chromothripsis is basically chromosome bursting out into shorter fragments, which was also identified in the previous study that I showed. We're all correlating with endocrine resistance. And I also said there is something called as an AID signature activity, which is correlating with endocrine resistance. And finally, this is something that needs further investigation. A correlation between the tumor microenvironment, the type of immune cells being present in the tumor has been established with endocrine resistance or lowered disease-free survival interval. So that needs further investigation to further understand why and how that is being mediated. So this in short tells you the various mechanisms by which endocrine resistance can occur at a molecular level in a patient who is treated with endocrine therapy. With this, I thank you all for your kind patience, and I can take up any questions if you have.
Thank you, Dr. Arun, for lucidly explaining the resistance, the biology of resistance that is going through, and a lot of work, a lot of insightful data actually that you presented, especially with Sudeep Gupta sir's data. And in our Indian population, we do know some of the mechanisms, but the things that you highlighted is something probably we have still not looked into, and probably that those are the pathways rendering resistance, and that is why our survival rates may not have been that great as expected. So a lot of things to still learn, and hopefully we'll be wiser in future. Thanks a lot.
Thank you, Dr. Annie, for the kind.
Thank you, Arun sir, for that excellent presentation and for helping us understand the biological basic. So we now move to our next scientific session. I invite two distinguished faculty members for this session, Dr. K. Meena, Consultant Medical Oncologist, AIG Hospitals, Hyderabad, and Dr. Annie Kanchanba, Associate Professor, Department of Medical Oncology, S.T. John's Medical College and Hospital, Bangalore. Over to you, Meena ma'am and Annie ma'am.
Thank you for the kind introduction, Ms. Subhashri. I'm just going to share my screen now.
Yes, ma'am.
Are you able to see my screen?
Yes, ma'am. Visible.
First of all, thanks to IAIO for this wonderful opportunity. It's an amazing platform. And thank you, Dr. Annie, for considering me for this topic. So Dr. Arun has very nicely explained how the resistant mechanisms come into play. And I am going to talk briefly about what are the therapies that we can consider and what will be the clinical implications of whatever he has explained. So we all know that breast cancer hormone receptor positive is the most common variant. Nearly 70% of the cases are hormone receptor positive, and among them, 30 to 40% cases are de novo metastasis. And we know that the treatment has evolved so much in ER positive breast cancer, and the space is now becoming crowded with multiple options. So how do we choose what to go with, what to go ahead with? So we know that at least in the de novo metastasis, we know that the first line setting is the best opportunity to extend the benefit and duration of endocrine therapy while maintaining the quality of life. And in this, when we go for a CDK4/6 inhibitor plus endocrine therapy, we have the maximum response with about 2 to 3 years. And that is the best response that we can give in the first line. And we have our options, Palbo, Ribo, and Abemaciclib. Obviously, we take multiple factors like the disease status, the financial constraints, and also the side effect profile while deciding what is the first line CDK4/6 we go with. Ribociclib has the strongest evidence, and it also has overall survival rate. So briefly, this was one of the presentations in this year, which I would like to highlight and emphasize because we need to understand resistance properly. Only then we will be able to target more effectively. So when a patient is endocrine naive, when they have not received any form of endocrine therapy, we presume that the individual will respond extremely well to endocrine therapy. And then we start off with that therapy. And then later, when they develop resistance, we just cannot label them in a blanket as resistance. We need to understand when they have acquired that resistance and how they have acquired that resistance. So the secondary resistance, if it is late acquired, which means the resistance happens or the relapse happens after 12 months of completion of adjuvant endocrine therapy, or if they have started as a metastatic disease, progression after 12 months of first-line endocrine-based therapy. This is considered as secondary resistance late acquired. This is important because there was substantial benefit with endocrine therapy, which means this tumor may still be endocrine dependent and we can change the endocrine agent and still have a good response. In contrast to that, once we go to the secondary resistance, which is early acquired, which is while on adjuvant therapy, but more than 2 years, or progressive disease more than 6 months, but within 1 year, the benefit may not be very effective. In this case, yes, we can still try to some extent with the newer agents like ACRDS, but it will be a tricky situation where we have to be extremely watchful for progression. Primary resistance, again, if it happens during the first 2 years of initiation of adjuvant therapy or within 6 months, and here we know that the endocrine agents may not be very effective, we need to identify what is the cause for resistance, and if there is any target, then we address that target. And if the patient responds even before that, it is known as endocrine insensitivity, and in such cases, we will have to look for options like chemotherapy or even ADCs or such options. So how do we choose the endocrine backbone for CDK4/6 inhibitor in first line? It depends on whether the disease is endocrine sensitive or resistant, like I have discussed with you now. So let us see one case where after endocrine therapy, the patient is having a recurrent disease or progression during or within 12 months of completion of adjuvant endocrine therapy. If the individual is having a PIK3CA mutation, which is tested either by solid tissue or ctDNA, and has not received any prior chemotherapy, there is a new drug, the inavolisib, that is being given along with palbociclib and fulvestrant in the first line itself. And this has shown a significant PFS benefit. We can see that there is a doubling of the PFS benefit, 15 months versus 7.3 months to the palbociclib fulvestrant. So this is showing that once we have a resistance, when we address that target, we will have a substantial benefit. It is based on this principle that this triple regimen is also being tested in the first line metastatic, which have PIK3 mutations. We know that PIK3 mutations may be both truncal or acquired. So far, even if we have truncal PIK3 mutations, we do not address it, but there are studies going on which are testing it in the first line also. So why are we looking at these resistance patterns and why are we trying to address them? So there are some studies which have shown that post-CDK, purely endocrine-based therapies may not be very effective. Again, multiple factors come into play here. Factors like what is the disease burden, factors like how much time it has taken to develop resistance, like I have told you, early acquired versus late acquired. All these play a role and in deciding a subsequent agent to get the best benefit. So this was one trial which has seen if we can continue the CDK4/6 inhibition and change the endocrine agent. This is the MAINTAIN trial, which has shown that if an individual progressed on first line ET with any CDK4/6 inhibitor and less than one line of chemotherapy, if they were given a switch of endocrine therapy versus switch endocrine therapy plus ribociclib, the benefit was seen. But again, the endocrine switch that was used here, nearly 83% of the patients had fulvestrant, and the prior CDK4/6 inhibitor used, 87% of the patients had palbociclib. And we can see that the response was present, but then it was present in individuals who had late acquired resistance. So it still is an endocrine dependent agent, endocrine dependent disease in which the benefit was noted. But now with our newer advances, we are able to identify what is the cause of resistance. And if we have a target, we need to address that. So what are all the mutations that we test? There is a biomarker guided selection now. We test for ESR1 mutation, PIK3 mutation predominantly. We have the AKT, BRCA, HER2, and to a lesser extent, there are emerging biomarkers like RB1 loss, FGFR amplification, etc. So why are we checking these mutations and how do these usually present? Like Dr. Arun has told, predominantly we have the PIK3 mutations and the ESR1 mutations. So PIK3 may be truncal or acquired also. Usually ESR1 are acquired. At de novo state, the prevalence of ESR1 mutations is less than 10%. It is only about 4 to 5%. But as the patient is having this strain after the first line therapy, we may see up to 25 to 48%. PIK3 may be present truncally also, but we do not address it until there is a progression of the disease. Usually they are largely stable over the disease course and they are associated with more aggressive clinical features in metastatic breast cancer. So now we know that we have to look for these mutations, but do we use tissue sampling or do we go for liquid biopsy? How do we choose? So when resistance happens, that resistance may be heterogeneous. So when we are going for a tissue biopsy, we may not be able to get the exact site where the resistance has developed. So these are some of the data which has shown solid versus liquid in breast cancer. And it was noted that overall there was a 60% concordance and 20% unique variants were noted via solid or liquid NGS. So what are the advantages of tissue or what are the advantages of liquid over tissue? Tissue is invasive. We go for ER/PR, HER2, PD-L1 testing. There is a limited insight to heterogeneity and may utilize archival samples. Sometimes that may become difficult and we may lose whatever that is we need to see. But liquid is non-invasive. It is unable to assess receptors. ER/PR and HER2, it will not give us information. But if we are trying to look for the heterogeneity and identify the mutations, this will reflect the heterogeneity. And it is an updating sequencing, which is done in real time. So generally, we have about 75 to 90% concordance between solid to liquid NGS samples. But is it the same in all genes or is it the same in all mutations? Not really. Because when we have seen in the ESR1 mutations, when they were tested, it was noted that there was a discordance between the liquid biopsy through ctDNA and the solid, and there was more identification of the mutation in the liquid biopsy with the ctDNA. In the CAPItello trial, they have identified, they have compared the same regarding the PIK3, AKT, PTEN mutations. And here also there was a discordance. ctDNA was able to identify it better. But the reverse is seen in PTEN mutations. Here there was maximum discordance, but here tissue was able to identify more mutations rather than ctDNA, where in ctDNA, if there were 43 alterations, only 29 were recognized. But in tissue, much more concordance was noted. So it depends on what is the mutation that we are trying to see. Ideally, a solid plus liquid would be a gold standard. We will not miss anything. But if we have to choose one, liquid biopsy will take precedence, because right now we have targeted therapy for the mutations that can be identified better with ctDNA. So now, after we have learned so much about how do we test and what do we look for, let's look at the treatment options that we have for ESR1 mutations. So ESR1 mutation, it happens, when it happens, we know that there will be a ligand independent signaling, because of which the activity will be accelerated. So there are some agents which will act on such tumors, and the emerging anti-estrogen mechanisms are here. We have the selective aromatase inhibitors. We know they only affect the ligand. They do not have any impact on the receptor. Selective estrogen receptor modulators, selective estrogen receptor degraders, PROTACs, which are the newer group of drugs which are coming up, proteolysis targeting chimeric, SERANs, which is complete ER antagonist, and SERCA, selective ER covalent antagonist. So now when we talk about ESR1 mutations, we have oral SERDs and PROTACs which are approved. These are, as of May 2026, these are the trials that are approved for the management of ESR1 mutant breast cancers, hormone receptor positive breast cancers. So these are the trials which have, these are the approvals that we have gotten in individuals who have had a progressive disease and these mutations were identified. So can we do a surveillance and identify the mutation even before the progression of the disease happens? Yes. But before that, do we do upfront NGS? Yes, we can do upfront NGS. That will help us understand the molecular profiling of the disease. But that will not help us in any way in therapy, because even if the PIK3 mutations are present, we will not act on that at that point of time. So generally, we do not, in India, considering the cost constraints and the resources, we usually do not do NGS upfront. But doing it at a later time will give us much more information. Now, this is one trial which has tested if ESR1 mutation surveillance can be done while the patient is on first-line aromatase inhibitor plus CDK4/6 inhibitor. This is the SERENA-6 trial, where patients were tested for ESR1 in liquid biopsy ctDNA with Guardant 360 every 2 to 3 months at time of routine staging scans. And when the mutation was identified, even before the appearance of new lesions or progression of the disease, the randomization was done to camizestrant plus continuing CDK4/6 plus placebo, or continuing AI plus CDK4/6 plus placebo for camizestrant, which means we are either replacing the aromatase inhibitor with camizestrant or continuing the aromatase inhibitor and waiting until there is progression of the disease. So this randomization was done and the stratification was done based on whether the disease had, whether the tumor had visceral or non-visceral spread, whether ESR1 mutation was detected at the first test versus at a subsequent test, the time of initiation of aromatase inhibitors plus CDK4/6, to what is the duration that they used, less than 18 months versus more than 18 months, and what was the agent used, palbo, ribo versus palbo versus ribo versus ebima. So what was identified? What was the primary endpoint? The primary endpoint was investigator assessed PFS, and it was identified that there was a progression-free survival of 16 months versus 9.2 months, and the hazard ratio is 0.44. So we can see that the curves are separated pretty much in the beginning, and that separation is maintained. But why are we not applying it right away in our population? What are the caveats?
Sorry to interrupt, ma'am. 2 minutes left for the session.
Oh, is it? All right. So there are certain caveats that because the OS is immature and it is high cost procedure, which is why we are not implementing Serena 6 as yet. Now, when we talk about elacestrant in individuals who were having ESR1 mutations and who have had after 1 to 2 lines of endocrine therapy and more than 1 line of chemotherapy, when elacestrant versus investigator choice, fulvestrant, anastrozole, letrozole were compared, it was noted that the PFS rate at 6 months and 12 months was higher in the elacestrant group compared to the standard of care, and the hazard ratio was 0.7 and 0.55. But in the subset analysis, it was noted that the benefit was seen in the group which had ESR1 mutations, and the benefit was seen in the groups which had at least 12 months of CDK4/6 inhibitors. Like I have told you, the duration of CDK4/6 inhibitors also tells us whether the tumor is still hormone sensitive. So another trial that has shown benefit is the EMBER-3, which tested another new agent, imlunestrant, versus imlunestrant plus Abema for patients with ER-positive HER2 post-endocrine therapy who have had progressive disease. So in this, there was one caveat that when they have compared imlunestrant and fulvestrant, they have identified that imlunestrant effect was better. But when they have compared imlunestrant plus abemaciclib, they have noted that imlunestrant plus abemaciclib was better. But there was one arm that was missing. That is the fulvestrant plus abemaciclib. So because there was no comparative arm where they could establish that imlunestrant plus abema was better than fulvestrant plus a CDK4/6 inhibitor, this combination has not yet received FDA approval, but imlunestrant has received approval as a single agent. So we can see here that there is a median PFS improvement from 3.8 to 5.5 in the ESR1 mutation arm with a hazard ratio of 0.62. And in the combination of imlunestrant plus Abema, there is an improvement from 5.5 to 9.4 and a hazard ratio of 0.57. And this benefit was also noted in individuals who had both mutations, the PIK3 and ESR1, which may be present in 20 to 25% of the patients. So this is CDK4 post prior to CDK4, but once we have a mutation, it is always advised to target that mutation. This is another important trial, the EVERA trial, why is this important? This is important. It is introducing another new agent, giredestrant. And this trial is important because 100% of these patients had prior CDK4/6 inhibitors. In contrast, the previous trials had patients who were only having endocrine therapy in 100%, but only nearly 50% of the patients had CDK4/6 inhibitors. Here we can see that the patients had received 2 prior lines or more prior lines of therapy. No chemo was given in any of these cases, and nearly 47% of the patients received fulvestrant also. And we can note that the benefit is seen in the ESR1 mutated arm as well as the ITT arm, but the benefit is substantial in the ESR1 mutated arm. So how do we choose? When do we choose whether we want to go for a single agent SERD or SERD versus targeted therapy? Because in all these trials, we can see that nearly 50 to 60% of the population have experienced no response or progression in the first 6 months. So this is because ESR1 is not the only cause of mutation in those cases. There were other factors also that played an important role, and ESR1 was only a subset. So when we identify a target, targeting that is very, very important. And SERDs as a single agent are very well tolerable, and they can be given in individuals who are old, frail, or they have only bone disease, or they are extremely endocrine dependent, can be considered in these cases. There's another new drug, the Protac, which was vepdegestrant, which has been tested and approved in advanced cases of hormone receptor positive breast cancer with ESR1 mutations. Brief word about PIK3, we have the alpelisib plus fulvestrant in SOLAR1, capivasertib plus fulvestrant in the CAPItello, and we have the INAVO, which we have already discussed. So like I have told you, we have to take the side effect profile into consideration when we are considering any of these agents for therapy. The hyperglycemia, diarrhea, rash, these have to be considered when we are giving an additional agent also, we have to see that the toxicity does not overlap. So Victoria has shown a new drug, gedatolisib, in the PIK3 mutated individuals in subsequent lines. So, and when we have other mutations like germline BRCA or AKT pathways and other mutations, we target them accordingly. So this is just a brief chart about what are the subsequent lines after CDK4/6 inhibitors plus AI in the first line. Dr. Annie will take us through the antibody drug conjugates, and Dr. Santosh, I'm sure, will conduct a very good moderation about the different clinical scenarios. Thank you all for your patient listening. Thank you for this wonderful opportunity.
Thank you so much, Dr. Meena. Thank you for accepting the invitation. I know it's a huge space and you've beautifully covered right from the resistance pattern and how we can use the mutations that come up at baseline and also while we are treating our patients, and what are the, I would say, hormone receptor positive is also becoming like a cafeteria approach where you have to look at the different mutations, patient profile, comorbidities, and then choose, and of course, the finances for our Indian population. Keeping in mind, times are exciting. There are so many options. Hopefully, we'll get them in future as well. Thank you so much for leading us through the entire armamentarium that we have right now for hormone receptor positive after CDK4/6. So going on, I'll be quickly going through the role of antibody drug conjugates. Is my slide visible?
Yes, ma'am, visible.
Yeah. So thank you once again, IAO, for this opportunity. It's a wonderful platform to discuss and to learn about new things. After Dr. Meena's extensive descriptive presentation, I will quickly go through the role of antibody drug conjugates. I would say the ADCs in hormone receptor positive have actually broken through the barriers after they have done wonderful job in HER2 positive metastatic breast cancer. So we will see how it has helped and what are the new things. This is just briefly about what is the incidence, which Dr. Meena has already said that it is hormone receptor positive is the most common subtype of breast cancer, and approximately 30% of them develop metastatic disease eventually. And we have different options that are there, which is coming up in first line, which has become standard. Second line is coming up, the space is becoming crowded. So we know that it is now biomarker driven strategy. We target the mutations. So what after these mutations? Where do these ADCs play a role? So this would be my agenda for today, how we select the patients, what would be the sequencing here, and what are the new developments in this space. So a brief introduction about the antibody drug conjugate. We know it has three core components. We all are aware about it: the monoclonal antibody, linker, cytotoxic payload, and they bind to the target, they internalize and then processed by the lysosomes, payload released, and we have the bystander killing effect. This is how the antibody drug conjugates work. So what are the antibody drug conjugates and what are their targets? What is their relevance in hormone receptor positive breast cancer? So the first one is the HER2 low and ultra low. So if we look at this from HER2 positive disease, it has now shifted to a HER2 low space, which is now discussed extensively, where the HER2 definition is changing. And of course, the pathology reporting becomes extremely important. The other receptor, which is the target, which is relevant, is the TROP2, which I will come to later on. And some of the emerging targets which are there is HER3, B7H4, LIV. So briefly about the HER2 low space. Historically, it was HER2 negative and HER2 positive only, but this historical classification has now been changed into HER2 negative and HER2 positive is either strongly positive, which HER2 positive disease is there, but in hormone receptor positive, HER2 ultra low and HER2 low is making noise because we have new drug targets which can help us improve the survival as well as the quality of life. So what we see here is, one is the HER2 negative, ultra low, where we can use these antibody drug conjugates. And we see that out of the patients who were initially deemed HER2 negative have now been termed approximately 50% of them into ultra low and HER2 low. So coming to what are the agents that are there in hormone receptor positive metastatic breast cancer, Enhertu, our favorite, which is making noise in HER2 positive with all the DB studies there. So here the target is HER2 low and ultra low, the payload being deruxtecan, which is a topoisomerase 1 inhibitor with a drug antibody ratio of 8. And we see that the linker is cleavable. The other one, which is there, is sacituzumab govitecan. The target here is TROP2 with the payload of SN38, which is also a topoisomerase 1 inhibitor. And here the DA ratio is 7.6. The upcoming one, which is having new data coming in, is datopotamab deruxtecan again, which has the target of TROP2. So where did Enhertu make noise in HER2 low space? So this was the DB06 study, where the patients who had progression of more than 2 previous ET or targeted therapy and had IHC 1+ or 2+ ish negative, they were randomized between Enhertu and physician's choice, given until PD or unacceptable toxicity, the primary endpoint being the PFS by blinded independent central review. So what we see here is we saw impressive PFS benefit here, 13.2 versus 8 months, with impressive hazard ratio as well. And mind you, this is in a population which has already been treated, and we are looking for new targets so that we can help survival. So we saw that apart from the PFS rates, even the overall response rates have been good in the overall population as well as in the HER2 low and ultra low space, with approximately delta of more than 30% in the response rate. So it has been, we see that this Enhertu has made its stamp even in hormone receptor positive breast cancer. And we all, just reiterating the side effects that come in, everyone is aware about the CINV that causes. Here we do ask to give at least a 3-drug antiemetic regimen. Important to note here is the interstitial lung disease, which we have to keep in mind and monitor well, because if we lose the window, we know that we are in trouble. Apart from that, there is other side effects which we have to look for, that is the left ventricular dysfunction, the other liver function test derangements. So this Enhertu was by DB06. By the other antibody drug conjugate that has shown some benefit is sacituzumab govitecan, and that was demonstrated in TROPiCS-02. Even here, the patients who have received at least 2 to 4 previous lines of chemotherapy for metastatic disease or had disease progression on ET CDK4/6 inhibitor, here the patients were randomized between sacituzumab and physician's choice of treatment, that was again chemotherapy here. So what did we see here is that we had benefit in terms of PFS, 5.5 months versus 4 months. And even OS benefit has been present, which was statistically significant. So here, what we need to notice, after the patients have exhausted their second-line therapy, after the CDK4/6 inhibitor, and also the newer agents that have come in that we target ESR1, PIK3CA, this is an option which could be given to our patients in the 3rd or the 4th line. And we see that all the subgroups which are there, HER2 low, PIK3CA, all of them had benefit with sacituzumab govitecan. This is one study which I would like to discuss. TROPiCS-02 had actually shown a benefit, but ASCENT-07 had something else to tell us. So this is a phase 3 study. Again, more than 1 line of therapy was given. Again, they progressed on CDK4/6. Here, again, it was randomized between sacituzumab govitecan and the TPC. Primary endpoint was PFS by BICR, and along with the secondary endpoints. What we need to note here is majority of them had endocrine therapy, at least more than 2 lines of therapy, that is around 60% here. And the CDK4/6 inhibitors were also used in more than 90% of the patients. what we see here is the primary endpoint actually was not met. Here we see that the control group and the ADC group had the same PFS of 8.3 with a hazard ratio which was not significant. But here, if we see here, the 6-month PFS rate was a little better in SG arm. And if we look at the PFS by investigator, here we see a 2 months difference. This just shows a bit of bias which can happen. Hence, PFS is generally recommended to be checked by the BICR. But what the authors say is, and what the discussion is, because there was censoring in the first 4 months, and if the patients had been shifted in the TPC group to the another ADC, that may have altered the median PFS that is there. So it is important that we look at what is the overall survival data that is not yet matured, because we need to look at the PFS2 as well. So sacituzumab, in this trial at least, we need to see in ASCENT-07 as to how many of them actually benefited with SG therapy by looking at the PFS2 and as well as the overall survival. So if we look at the subsequent anti-cancer therapy here, we see that in the control group, at least 60% of them actually received ADC in the subsequent line compared to the SG group. So I think before we say that the PFS did not show any benefit, we would like to see the overall survival benefit to actually say that SG just doesn't work. And even because the response rates also have been similar in both the group, again, the bias would have been there because ADC being used in the control group and censoring done at 4 months. So if we look at the toxicity profile of these two ADCs, TDXT, the CINV rate is high, ILD, fatigue, neutropenia, alopecia is there. Sacituzumab govitecan, the primary toxicity, diarrhea, neutropenia has been mentioned, which is primarily because of its unstable linker and gets released slowly extracellularly, because of which the suppression is there. The nausea fatigue is also well mentioned with the SG. So coming to the upcoming datopotamab deruxtecan, which is going to be launched soon in India as well. So apart from HER2 positive, even in hormone receptor positive, they have used Dato-DXd in patients at least 1 to 2 lines of therapy before, and they were randomized between the HER2 0, 1 plus and 2 plus. And if we see that again, here it is randomized between Dato-DXd single agent versus the chemotherapy. So here the initial data does suggest that the PFS benefit has been there with Dato-DXd, but important. And if we look at the plot here as well, it showed benefit across all the subgroups. But it would be important to note how we would choose Dato-DXd and Enhertu in HER2 low space, because we have seen that in DB06, the PFS rates, data was pretty good compared to what we see in the Tropion-Breast01 study. So the upcoming data would actually help us to choose and decide which ADC would benefit, at least in the HER2 negative space, not in the ultra low or low space. So this is one of the database cohort C. This is just a small cohort of patients of 10 who had leptomeningeal disease, and Dato-DXd was used. This was presented by Dr. Paul at SABCS last year. This is just to say that in leptomeningeal disease, also Dato had worked, especially those who were heavily treated, and they had shown benefit in terms of PFS as well as the median OS patients. So if we have to slowly summarize and to see how do we sequence ADC in hormone receptor positive, we see that yes, we do have other option which we can use apart from chemotherapy in 3rd and 4th line. And how do we use this? As you can see here, First line, second line, Dr. Meena has beautifully explained this red box here and how we can make use of the mutational landscape to help and choose which therapy to give our patients. This is where antibody drug conjugates can help. In HER2 low space, it is T-DXd. If 2 or more chemotherapy, sacituzumab govitecan, and of course the other targets that we can look for, NTRK, MSI status, RET, in which we could use the targets accordingly. And this was presented ESMO Breast 2026. So this is the space probably where the antibody drug conjugate could help in improving survival. So if we have to strategize and say where do we use antibody drug conjugates, that would be probably in the third and fourth line. And of course, it will depend heavily upon the HER2 IHC status, the prior therapies, the patient preferences. And so this is how we would consider in our patients after they have exhausted the first, second. For the third line, we need to see about the markers, the mutational landscape, the comorbidities, and of course, at the last line, we have the chemotherapy, which would be our go-to regimen. So this space has become interesting. We have new ADCs coming in. Datopotamab is the newer ones are in pipeline. Patritumab is there. And important to note here is there are studies which are actually using combination of ADC with endocrine immunotherapy and targeted therapy. So these are some of the combination therapies which are being explored. And if we look at the pipeline, it looks pretty interesting. So there are phase 2, phase 3 trial targeting HER3. There is phase 1B trial of HER2 positive plus PI3K. The targets here which are in pipeline B7H3. And important to note, I would like to draw your attention to this, which is a phase 1-2 trial where they're using T-DXd plus Pembro. And this is in sync with what Dr. Arun had told, that one of the mechanisms of immune response. So what they say is what the preliminary data came from Destiny Breast 08, where they actually explored T-DXd with other agents being used in hormone receptor positive and saw the safety analysis. From there, they understood that yes, the cell death from DXT may actually help gain the immune response. So I would say this is the space where T-DXT plus immunotherapy may give us more information and also give us data to use these combinations to overcome the resistance that are developed in due course of time. So times look exciting. These are some of the emerging ADCs. So here we need to see the resistance mechanism, use our biomarkers for precise targeting so that we can optimize our dynamic ADC sequencing. And of course, the novel payloads are coming in, newer generation dual payload ADCs are coming in. So this would be my last slide. ADCs do have shown a paradigm shift. Destiny Breast 06, Tropic 02 are there. And we have evidence that there is sequential ADC strategy as well. Important to always remember the side effects profile, because these are new drugs coming in and we need to use the therapies diligently and also ensure that the quality of life is also maintained. So we have exciting times ahead. As I mentioned, the pipeline also shows newer agents, the combination where they're using synergism, so that we could have more options available for our patients. So this would be my last slide. Thank you for this opportunity.
Thank you, Meena ma'am and Aunty ma'am, for those highly informative presentations. So we will now move to one of the most interactive segments of today's program, the panel discussion. I'm pleased to introduce our moderator for the panel discussion, Dr. Santosh Kumar Jelapuram, Senior Consultant Medical Oncologist and BMT Specialist, Star Hospital, Hyderabad. Joining him are our esteemed panelist, Dr. Sanal Fernandez, Assistant Professor Medical Oncology, St. John's Medical College, Bangalore, Dr. Sindhura, Consultant Medical and Hemato-Oncologist, AIMS Hospital, Delhi. Dr. Nivedita Sen, Junior Consultant Medical Oncologist, R.N. Tagore Hospital, Kolkata. Dr. Dhiru Talukdar, Consultant Registered Oncologist, Barpeta Cancer Center under Assam Cancer Care Foundation, Assam. I warmly welcome all the panelists. And Dr. Santosa, the virtual podium is now yours.
Right. Thank you, IAIU. Thank you, Annie, for having me. It's good to be, I think, seeing a lot of old friends. I think two fantastic talks by Dr. Arun and Dr. Meena. Although Meena stays beside us, very rarely we see over the conference. So I think I invite my panelists to participate. I think there are many areas in management of cancer where we don't know what to do. So these are the things that I want to discuss. Are we right taking the decision? Are we wrong taking that decision? What is the science backup? This is where I would dwell upon in our talk. I think I would also request Dr. Annie and Dr. Meena to join the discussion in between so that we can have more expert inputs in managing one of the cases. So during this preparation, I have used some of the AI elements in preparing. So I think this is one of the slides that gave. Apologize if the images doesn't look like you. So this is what AI has given. That is one thing. So this is a slide that was taken from the recent ASCO 2026, where it has compared the agents that we have way back in 2015, where we have only 4 agents, the tamoxifen, aromatase inhibitors, fulvestrant, and the Bolero kind of strategy. From there, we have moved into current area where we have more than 13 plus targeted agents. So we have plenty of things. So the ideal guidelines, what they recommend is first line ET plus CDK4/6, followed by ET plus targeted therapy based on PI3K, AK3 oral set, then given ET. So 3 lines of ET followed by chemotherapy and ADC. We had talks of Dr. Meena who covered this aspect. Later, Dr. Annie covered the later aspect. So what happens in real world is most patients receive only first line of ET. This was the analysis after first line of CDK4/6. 42% in MD Anderson would receive chemotherapy, and this is the thing. So second and third line, most people receive this one. So with this, I would directly start with the case presentation. The first case, it's in front of you. So 52-year-old lady, postmenopausal, presented with breast lump and 4 bone lesions. Strong hormone positive, Ki67 of 80%. Good performance status. She wants the most aggressive treatment. That is what she tells. She wants to get rid of the cancer and at the same time have mild to moderate side effects. So this is what it is. So with this profile, I think I would ask Dr. Sanal. So what do you see this patient? Would you cure it? Would you palliate her? What do you see?
My intent would be curative, sir. I'd still go for curative.
You go for curative. Okay.
Yeah.
So, Dr. Sindhu?
Yeah.
Dr. Sindhu?
In the presence of 4 conditions, curative.
No, I missed you. You curative?
4 conditions falls under oligometastatic, so curative.
Curative. Dr. Nivedita? Is Dr. Nivedita there? Dr. Dhiru?
Sorry. I just forgot to unmute myself. So definitely my intention will be curative. So I would like to go ahead with the curative intent treatment.
Yes. Dr. Annie?
Again, curative, sir. It's bone only and only 4. So, and she wants the best treatment ahead. You should give her a chance. It comes under that.
Wants the best treatment. Every patient wants the best treatment.
Yes.
Okay. Dr. Meena, if she's there. Dr. Dhiru? Okay. So our panelists unanimously agree. Before embarking on this one, would any of you want to do some NGS at baseline to see what exactly is happening, based on which you would choose upon the curative or palliative? Do you want to do or understand the mutation panel at the start? Because in hormone positive, we have the data of PIK3 targeting upfront using the Ivanolazib kind of data. So what is your general practice? I would start with Dr. Sanal.
I think that's an interesting question, sir. I mean, it's an evolving space in terms of mutations, but as of today, I would not opt for an NGS at baseline.
Okay. We know that PIK3 is from start. Okay. Patient asks, she wants the best and latest advanced treatment. So we have the triplet data of ivanolazib with overall survival benefit. So she asked you, sir, I have read somewhere in ChatGPT, sir, PIK3 testing, you have not advised. You are working at St. John's, Bangalore, a lot of techies would come. So how would you manage? Sanal?
The data for ivanolazib is still in the palliative setting, sir. I don't think it's in the curative setting. Yeah, so if you're going with the curative setting, I would tell her that we'd still go without an NGS with a more conventional approach.
Okay. You want to know BRCA status and all?
Yeah, I would opt for BRCA status, but like the chance of a BRCA positivity in this patient is on the lower side. But yeah, I'd probably get a germline panel done.
Okay. You would do Dr. Sindhu? Any testing would you do, or you would agree with Dr. Sanal and get away with no testing, directly curative, bombard with patient?
Would largely go with what Sanal had said, but again, PIK3CA is probably more important in prognostication as of now, especially in a metastatic setting. And so far, we haven't, so far, inavolisib is not available in India. That is also probably driving our decision of not going for NGS at the baseline. Rest of all the things, I agree with Dr. Sanal.
Dr. Nivedita, would you agree with two of your prior panelists, or you want to do something else?
Yes, I would. If there is a strong family history, I would like to take that also. So in that case, if there is multiple strong family history, then we can go ahead with the BRCA testing as well.
So do you require any family history to do BRCA testing, or presence of breast cancer is sufficient to get?
Ideally, in all HER2 negative cases, we should go ahead with we can do a germline BRCA testing. So as she's
do BRCA testing, because there is emerging data from AIIMS, Tata Memorial, that everybody should undergo BRCA testing with any breast or ovarian cancer. Dr. Dhiru, available?
Yes, sir. I definitely go with BRCA testing, irrespective of the stage.
Yes. Okay. So a lot of my panelists have agreed that they would go with curative setting. So Dr. Sanal, how do you go? You give chemo, or you want some neoadjuvant hormonal therapy using CDK4/6 and later do something, or is there any other way you want to proceed in this case?
I mean, there are two streams of thought here. If we were going for a neoadjuvant, I'd go with chemotherapy at this point in time. The other thing is, I mean, we could also go with upfront surgery with a mastectomy and then give radiation to the this thing followed by systemic therapy.
Okay.
Yeah.
So do upfront surgery. Okay.
Yeah.
Right. Interesting thought process. I would ask the other panelists whether they do same. So the other thing is, especially in regards to the neoadjuvant and all, would you want to give dose dense, or how do you want to go?
That's to me, sir, or that's to Sindhu?
Yes.
Yeah, I think conventional 3-weekly.
Brilliantly. So you want to give chemo, and do surgery, and then do that's what you want. And the alternative option is do upfront surgery and later
with the bone lesions and then give systemic therapy.
Systemic therapy with chemo or hormonal?
Based on the nodal status and this thing.
Nodes negative.
Nodes negative, then if it is this is so what is the grade? I didn't see the grade in the previous this thing.
67 is, I think, very low, 18%. So it's grade 2.
It's grade 2. Yeah.
So after surgery, you want to give chemo?
No.
Only hormonal.
Only hormonal, yeah.
Okay. So Dr. Sindhu, we have a different perspective from Dr. Sanal. I want to ask you whether option 2 is feasible. That is doing upfront surgery.
So,
then
going on for an it's a oligometastatic disease, so I would always err on to the side of systemic therapy first, and then consider local therapy depending upon the response, and also it would be like an NACT followed by surgery, SBRT to the bone, and radiation to the primary as per the requirement. This is what would be the sequence that I would follow.
Okay, so you would not do upfront surgery.
No.
Dr. Nivedita,
Yes, I agree with Dr. Sindhura that I would go ahead with the systemic therapy first and then reassess the response and then go for surgery and focal artery to the bone lesion.
I'll ask you one
By
question.
hormonal.
Why not give a neoadjuvant hormonal therapy? Because the Ki-67 is 18%.
Yes, it is a strongly hormone positive disease with Ki-67 18%. So yes, hormone therapy can be considered, but she's a relatively 58 years old female. So I think I would have gone for a neoadjuvant chemo followed by responses.
Okay, right. Dr. Dhiru, would you consider some hormonal or would you consider chemotherapy also in your case, in this case?
It is a oligometastatic disease, sir. So I will consider chemotherapy first, followed by surgery assessment, then followed by SBRT to the bony sites, and then hormonal therapy.
Dr. Annie?
So I have chosen for a curative, so NACT, surgery, RT, and hormonal therapy.
So neoadjuvant hormonal wouldn't be curative?
So hormonal therapy takes 6 months at least for it to act. It will be too late. So if I have chosen first itself that I'll be going in for a curative, I would go with the standard protocol, which is there, NACT followed by surgery, RT, and hormone.
Okay, so I think there are two ways of treating it. So we have explained to the family the option of surgery going aggressively. Ultimately, owing to the side effects and all, they did not agree with the upfront curative kind of thing. They wanted a hormonal kind of strategy, which is not wrong in this scenario. Suppose the patient doesn't want chemotherapy, or in this scenario want a neoadjuvant hormonal kind of thing. What kind of CDK4/6 would you be wishing to give, Dr. Sanal? And assume this is only bone-only metastasis.
Bone-only metastasis, and this is now palliative because the family is not willing for surgery.
Okay.
I'll be comfortable with either of them, sir. Palbo, Abima, or Ribo. I don't think there is a particular preference.
Suppose the patient asks, sir, I want only one tablet. I don't want 2 tablets. So bone-only metastasis. So are you comfortable giving without CDK first line, changing to or adding CDK on progression? So is that option feasible? We have data, SOFIA or SONIA trial where irrespective of the CDK4 is up first line or second line, the OS is same. So considering this, would you omit CDK4 upfront?
I don't know what the other panelists would say, but I think I would not be comfortable with giving only an AI. So I would like to give CDK4/6 plus.
AI plus fulvestrant?
No.
No. Is there
CDK4/6?
Dr. Sindhu?
So the first line, if it is a CDK4/6 inhibitor, either of the 3 would be okay. Preferably Ribo because of the data. Rest, I'm comfortable with any of them. But if a patient wants to choose a single AI, I would not really suggest. SONIA trial is the only trial which had actually evaluated that aspect, and it's still skeptical to accept the fact that it's about the OS difference. Again, hormone resistance plays different in each individual. So I think CDK4/6 plus AI would be my first choice.
Oh, right. So CDK4/6 with AI. Dr. Nivedita, would you choose any?
I would go ahead with the CDK4/6 and AI, and fulvestrant, as you asked, fulvestrant and AI can be given in older patients, or if there is poor tolerance to CDK4/6 inhibitor, but it is not as per the standard practice. It is an alternative option as a first line, but my options will be like to go ahead with the CDK4/6 along with AI.
Right. Okay. So my panelists predominantly agree to a curative intent in this oligometastatic, which I do agree. But we always discuss with the patient, and ultimately in this scenario, the patient was started on ribociclib plus letrozole with the bone agent. After 5 months, PET scan was done, complete response, patient very happy, doesn't want any treatment. She wants that PET scan is normal. Sir, what do you do? So patient is in front of you, Dr. Sanal, after 5 months of ribo plus this one. These are the options in front of you. Would you continue same, do local surgery, RT to all sites, RT to bone sites only without local surgery? Would you want to do any special serial test? Or do you want to change to chemotherapy and cure the entire clone? Or any other option do you have in your mind?
I think I'll go for continuing the same, sir.
Why don't you go curative, do local surgery and radiation to 4 lesions? What's wrong?
She seems to be doing reasonably well. She's responded well to CDK4/6 plus AI. Do you really want to change a winning regimen? I am not sure.
Winning regimen, but it would be a lifelong treatment. So will it give a chance of cure? Possibly if I do a surgery and RT to all sites, possibly I could eliminate the disease.
Yeah, I think, but yeah, I mean, it's tempting, sir, but I think it's also hypothetical. So I would probably continue with the same.
So in future, would you want to change your strategy? Suppose 5 months later, PET scan normal. Would you want to do something else?
I mean, 5 more months, sir, down the line, that's like 10 months. I would continue the same, sir. I would continue the same.
Dr. Sindhura, Sanal wants to play safe. He wants to continue with the same protocol, which is the winning combination. Do you want to do something extra for your patient, or you want to be the same?
So this is basically a very tricky scenario. So most of the patients will do good at 6 months. Most of our patients, whether they have a PIK3 or whether they don't have a PIK3, whether they develop a ESR, usually they're okay at 4 to 6 months. I think it's better we observe for a longer duration of time before we take a call of local surgery and RT to all the sites. So I wouldn't do it at least before the usual PFS of all the CDK4/6 trials.
Okay. So you want to continue, possibly do
Continue, and I wouldn't eliminate the local surgery and RT because, again, going radical in a limited disease for her, especially with 4 metastasis, I think it's sort of a neoadjuvant hormonal therapy followed by a local therapy. We are not wrong doing a local therapy, but again, I would wait for a longer duration before I take a call.
Dr. Nivedita, is there a data of doing local surgery and radiation in a metastatic disease to achieve a cure? What is your viewpoint on this? Suppose in this patient, we do an RT to all the sites and do local surgery and make her cure. So is it a validated strategy or I'm doing an overkill?
No, I think I would wait for another few months to see the response. If this is sustained response, then I can discuss the possibility of cure with the patient because initially she refused surgery. So it's a shared decision between the physician and the patient. So although there is no robust data at present, but after discussing if the patient is willing for, we can explore the option of cure.
So I think you would discuss. There are 3 to 4 trials that have attempted answering this question. Among this, the uniform is those patients who have good systemic control over time with bone-only disease. These are the patients where doing local surgery will give a good long-term overall survival. If I want to do any kind of complete curative surgery, this is the kind of patient that I would do. Possibly wait for some more time, see the disease stability, and then do. So, Dr. Anna, Dr. Dhiru, please proceed.
Yes, sir. I'll go with the same treatment, but the thing is that patient is having lesions in the bone in the pelvis also and also in the spine. So I'll consider it to be to have radiation or SBRT to that area, depending on the Mirel scoring actually. If it is like
completely stable means no pain, nothing, no pain, no instability, completely fine.
So then I'll continue observing the patients on regular follow-up.
And importantly, in this scenario, the PET scan is normal. In a normal PET scan, when the bone lesions are not visible, will the radiation oncologist be comfortable giving radiation there?
No, sir. I'll continue observing the patient on close observation, and will keep the patients for further treatment with consideration of RT to the associated site actually.
Dr. Rani, we had a discussion by Dr. Meena. possibly doing some serial test and something.
So Serena trial was there where they actually saw and they did this ctDNA and saw the emergence of ESR1 mutation, based on which they actually had changed the therapy. But again, I think that is something which could be done and offered. This is something new which has come in and was presented. What I would like to add here is I would like to continue the same treatment, and considering that we have embarked on a palliative initially, probably we could discuss the NGS upfront also, because she was not willing for surgery. So I'm not very sure at this moment also how much she will be willing to undergo surgery. So in our scenario, generally, we will continue the same. And about the question about serial tests, I would say ctDNA with looking at the mutational profile could be one option which we could add on here.
Yes, possibly yes. I think a lot of times the treatment decisions are dynamic. Sometimes upfront the patient do not agree. The things change over time. I think we have to open to discussion and see what best we can do. I think I think we have 5 minutes of time. We'll discuss the second case. This is a 58-year postmenopausal lady. Breast with axillary nodes and multiple extensive bone metastasis. She was started on anastrozole, palbociclib, zoledronic acid. 24 months she was in response. Now, what happened? She had breast-only progression. The remaining bone lesions are completely in remission. So this is the current scenario. You have done a PET scan at 24 months, where at bone you are finding stable disease, but there is local only progression. This is the scenario. Dr. Sanal, what would you do in this scenario? Would you want to continue the systemic therapy beyond?
So I'd like to do two things, sir. So the one is the local therapy. So probably give radiation to the site of progression, that is the breast primary. And I wouldn't advise a surgery.
Axilla?
The progression is only in the breast, right, sir? Or is it both breast and axilla?
Yes.
Breast, yeah. So breast. And then the second thing, I'd probably request for an NGS now.
NGS, okay.
Yeah,
You would do
those are two things. Yeah, those are two things I'd do. Yeah.
Yes. Dr. Sindhu, Dr. Sanal has told that he would irradiate at breast, but the patient has no ulceration or no pain or no bleeding, only symptomatic increase in size. In this scenario, would giving radiation be an ideal strategy, or do mastectomy is a better strategy, or completely change the entire systemic therapy and do nothing locally is the strategy to do? What would you do?
Any local therapy ideally would be the choice for this patient. It can be either surgery or radiation. Now that the surgery for breast is not a morbid surgery, I would probably think in lines of a surgery, because progression in breast on hormonal therapy, subsequently, these are the patients who would develop skin involvement and all the fuss, ending up into a toilet mastectomy sometime or the later. So probably I would think of going for a local surgery in this patient rather than radiation. Unless until there is a contraindication or the patient is not willing for the same.
We have two different opinions from our panelists. One willing for radiation, other possibly surgery. How would you go in this case?
I think if the symptomatic increase is not that significant without any bleeding, ulceration, then we can only, and she has been doing substantially well for approximately 2 years with the CDK4/6 and AI. So here we can change the endocrine partner and see what is the response. And then if she is not responding, if there is further progression, then we can go for another local therapy.
Okay. So you want to continue same, change the systemic therapy. In this scenario, two questions for you. Would you continue the CDK4/6 or would you change the CDK4/6? She's on palbociclib. So would you want to change it, or you want to continue the same CDK4/6 with changing to fulvestrant to AI to fulvestrant?
As per the data, I think post palbociclib, we can change the endocrine. There is only local progression, and we can change the endocrine partner as well only and continue palbociclib.
I'm asking palbo to ribo or abima.
I think as per the maintain trial, they were changed to ribo. I think I would prefer ribo in that case.
Okay. So you want to change both the agents, palbo, letrozole to you want to change to ribociclib and
And
fulvestrant
fulvestrant.
and wait for the local site.
Yes, sir.
Dr. Rani, would you agree with this or you have any other plan?
So for all practical purposes, this is metastatic breast cancer first, and we have embarked on a palliative treatment with CDK4/6 AI. So and you said only breast is what something which has just increased a bit. So one thing is I would just change the hormonal agent here, probably convert it into fulvestrant, but I would like to get an NGS here and wait NGS here so that I know if there is some mutations which have developed, because she has achieved a PFS of 2 years, which is generally seen with a Palbo. She has actually crossed with Palbo data that we have, and this is the time when the mutations may develop. So local therapy, I would not offer it immediately if it is not showing anything extra right now. I would just change the hormonal, and based on the NGS, would like to change it further if required.
Don't you believe the data of changing CDK4/6 to another CDK4/6?
So here it depends upon how much is the progression, because I know Maintain is there where we have converted Palbo to Ribo and also of a better agent. But here, if we look at the progression site, it's only local, which is just a symptomatic, which is there. So
your what? NGS, you got ESR1. So what is your treatment?
If ESR1 is there, then here again, if the patient can afford, probably we would give a ESR1 directed therapy add on to that, and because we know that is the one that is driving giving the resistance here.
Which agent? Patient can afford anything.
So here I would, if ESR1 is there, then we have this data which has come with our elacestrant, the SERDs which have come in, and so I would give that option and change it there to add a SERD here.
Dr. Dhiru, if the NGS is PIK3, what would you give?
If PIK3 is there, then on that direction only we have to add on the previous treatment, as because only breast change is there and there is no change in the metastatic side, so local therapy will not go ahead.
Okay. So, Dr. Nivedita, you get a report of presence of both ESR1 and PIK3. What did you?
If it is both positive, then I think alpelisib is a difficult drug to tolerate also. So I need to keep in mind regarding the possible side effects, hyperglycemia and all. So if logistics are not constrained for her, then I think elacestrant can be used in her case.
Elacestrant alone. So how do you manage the PIK3? Elacestrant manages ESR1. So would you want to add some everolimus kind of strategy? Everolimus exemestane or everolimus plus fulvestrant?
If it is ESR1 mutated or if it is ESR1 not mutated.
Both mutated. If both mutations are there.
Okay. If both mutations present.
Dr. Sindhura, if both mutations are there, how would you go about?
If both the mutations are there, probably alpelisib plus, everolimus plus fulvestrant or everolimus plus elacestrant. We don't have the data for combination of everolimus plus elacestrant, but again, oral only regimen could probably, we can extrapolate and use is what I can.
Dr. Sanal, if both are absent, if it's wild for both.
Then surgery.
Sanal, no mutation. You did an NGS and all.
No mutation, then local therapy, RT or surgery, and continue CDK4/6 plus
yes.
AA.
Would you want to change, or it's being a liquid biopsy, would you want to do a after surgery NGS in that? Because sometimes liquid biopsy might miss.
So if you're going for surgery, I'll send it for somatic NGS, sir.
Somatic NGS.
Yeah, especially when it's a site of progression, yeah.
So you will change the CDK4/6, I think. Yes or no?
No, I will not change the CDK. If I'm doing the local therapy, then I will not change CDK4/6. I will continue the same.
Right. I think in this case, we have done a local surgery, change CDK4/6 and continued. She's, I think, 1 year post that, doing fine. I think we have time, organizers. Shall I wind up? Shubhashri is there?
Yes, sir.
Do we have time or shall I wind up?
So we have time. If your slides is not
Completed in 3 to 4
completed,
minutes.
so
Okay.
yes, sir.
I'll complete in 3 to 4 minutes. We
Yeah,
have
sure.
5-year-old lady. So presentation was with low backache and swelling of the breast. So at present evaluation, she had a primary tumor in the breast, bulky area which showed thrombosis. She had skeletal burden with sphenoid bone metastasis also, multiple mixed lighting, but the compression was in the pre and paravertebral epidural area. So she has widespread skeletal, but she had D8 which was unstable and thrombosis. So she underwent decompression and at the same time stabilization because the spine was unstable. So interestingly, the primary breast biopsy and also the tissue from the paravertebral area shows this kind of thing. Loss of E. cadherin with strong hormonal positivity, low Ki67, HER2 finally negative on fish. So this is a lobular kind of strategy. In this scenario, what would you do? I would start with Dr. Sanal again. Lobular breast cancer with multiple bone lesions, you have stabilized the spine. So what would you do, Dr. Sanal?
I think I treated like hormone receptor positive IDC only, sir. CDK4/6 plus AI.
Yeah. So lobular, do you want any different strategy or anything?
No, I wouldn't change anything at this point in time. I think I'll stick to CDK4/6 plus AI.
As Dr. Sanal said, we continued letrozole and palbociclib, and we continued and gave radiation. Would you agree giving radiation?
Radiation, if it's been surgically treated and if she's not symptomatic at other bony sites, I think I wouldn't give radiation, sir.
I think especially in the bed, possibly there would be some metastatic disease that are there. So we sometimes irradiate whenever post-surgery, post-cavitary radiation, some kind.
Post-cavitary radiation.
So what happened is she started developing neurological symptoms after 3 to 4 months in form of what do we say, cranial nerve palsy. Evaluated, found to have multiple leptomeningeal disease and CSF is positive for malignant cells. So at this scenario, how do we proceed? Dr. Nivedita, 4 months of Palbo and AI, patient has leptomeningeal disease, and when you do CSF, lot of cells are positive. Dr. Nivedita.
Yes, sir. So it appears to be a primary endocrine resistance that is happening within 4 months. And the disease biology is very aggressive. So I would like to go ahead with the NGS at this moment. And as she's symptomatic,
NGSN, ESR1 PIK3 negative.
Okay, NGSSN and ESR1 PIK3 is negative. Yes, so if she's symptomatic, then and she was HER2 negative, 2 plus, low HER2 she was.
Negative, strong hormone positive, low Ki67 with lobular hysterectomy.
So in this case, I can consider chemo also for this patient because she is very symptomatic at this moment and she has a very aggressive biology disease with the progression within only 4 months of AI plus CDK4/6. So but I would like to go ahead with.
Clinically, the breast mass has reduced.
There is only isolated CNS.
Yes. Yes.
Okay.
Okay. Dr. Annie, Dr. Dhiru, what would you do?
First of all, the case is coming with multiple lesions in the leptomeningeal disease. So it is a very, very extensive disease in the brain. So I'll go with medical decompression therapy first so that the GC becomes improved. And also I'll give whole brain RT to this patient. So after that, only further further treatment will follow.
Okay, you want to give whole brain RT, anything to the spine because it's a leptomeningeal craniospinal irradiation you want to give?
No, sir. In breast, no, not cranial spinal irradiation, but independent.
In this case, these are all leptomeningeal kind of disease. Dr. Annie, what would you do?
So I would not give RT here. There's no parenchymal disease. This is CSF positive and leptomeningeal. So here, as in the baseline, she had HER2 2+. Here, antibody drug conjugate could be used here. That is NHER2 because
the bone lesions have responded beautifully.
Still, I think here bone lesions have improved, but the brain LMD is present, which actually is quite aggressive. So I would have changed the systemic therapy here, sir.
The patient doesn't have a cost for ADC. No
Then
trust.
chemotherapy and intrathecal therapy, MTX.
And one thing is, especially these kind of lobular breast cancer where the cadherin is lost, these patients tend to have weird disease with peritoneal disease, sometimes with sphenoid metastasis, sometimes with brain metastasis. So possibly the different point of view of viewing this case is the patient responds systemically. CNS, it did not respond. Possibly the cells are hormone positive and sensitive, but your agent did not penetrate the blood-brain barrier. So could this be a possibility? Because of that, there is leptomeningeal disease. Dr. Sanal?
Yeah, so I have a different point of view. So I think I agree with what you said. Systemically is responded. I would give WBRT if she's symptomatic, and I would probably change to abemaciclib plus letrozole, purely because it has better CNS penetration.
So you do abemaciclib, letrozole,
and plus or minus WBRT.
Won't you do intrathecal CSF positivity leptomeningeal? You don't do. Okay.
No.
So this case is from Dr. Sindhura. I think with the various point of view from various panelists. Dr. Sindhura, what did you do? Can you explain?
So basically, this patient initially had a very small breast lesion, extensive bone lesions, and left neck mass, which was probably malignant itself, but we could not prove that. So initially, since it was lobular and strong hormone positive, we thought of starting with a CDK4/6 plus AI. So initial choice, because of the patient's constraints and all, was palbociclib, though I understand that extensive bone metastasis, probably the other two agents could be better in tolerating the cytopenias. So when the patient was being planned for palliative RT to the bone, that is when we had got an MRI done of the brain to look MRI of the brain, primarily because there was a sphenoid lesion also, base of sphenoid lesion. So during that, there was focal leptomeningeal enhancement, which was there. So subsequently, we evaluated after the whole palliative RT was over. Patient was not overtly symptomatic for the new leptomeningeal thing. So that is when CSF was positive. We had to accept that this is lobular with a different type of a disease presentation. Eventually changed to abemaciclib plus letrozole and continued on triple intrathecal. After 2 intrathecals, then the patient's CSF has become negative. We are now continuing on abema, letro plus TIT.
So yes, so this is how this case was managed. Subsequently, a PET scan luckily showed complete anatomical response.
Yes.
And very good response. She's continuing on this. So this is a different, very rare case. Sometimes lobular has this interesting. That's the reason I wanted to put forward. So I think we have an oligometastatic HER2, the case one where they would be curative and the palliative based on case to case. We decide, we see, and always try to aim to remove the disease. And we have local only progression where we do the local strategy and continue the systemic strategy, and very rare lobular case where we do something differently. With this, I think I would conclude my session. I thank IAIO, Dr. Annie, and all my esteemed panelists for sharing their point of view. I really enjoyed interacting with you and seeing Dr. Sanal, Dr. Sindhu, also I see daily, Dr. Sanal, Dr. Annie, everyone. So it was a fantastic. Thank you. Thank you for your point of view. I think this tells us the cases we see are very, very complex, and a case can be treated in multiple ways. It depends on the logistics, the patient's expectations, the place where you treat, the local protocol, and the expectations of the patient. So this is the point of view I want to bring forward during this discussion. Thank you. Thank you again.
Thank you, sir.
Thank you,
everyone.
sir. Thank you, everyone, for this enriching discussion. So As we come to the end of the today's session, I would like to thank all our esteemed faculty members for sharing their knowledge, experience, and clinical insights. A special thank you to the program director and all the faculty members for making this program academically enriching and highly interactive. I also extend my sincere thanks to all participants for joining us and contributing through your questions and engagement. We hope today's discussion will help improve evidence-based decision making and the patient outcome in HER2 negative and positive breast cancer. Thank you, everyone. Have a wonderful evening and stay safe. Thank you. Good night.